Second talk for the day is done by Dr. Raja Da. He's going to talk to us on modern evaluation of patients with bronchiectasis. Dr. Da is a director of and the head of the Department of Pulmonology, CK Bala CMRI Hospital, Kolkata. And he's the director of the Research and Education, National Allergy, Asthma, Bronchitis Institute, Kolkata. And he's the Indian representative for the ERS, the European Respiratory Society, and he's the honorary executive committee member of the Indian Chest Society. And he has 46 international and national publications in index journals and abstracts along with 12 book chapters. So Dr. Da will join us with a recorded speech, and he will join for Q&A after the talk. Over to you, Dr. Da.
Morning, friends. I bring you greetings from India. It gives me great privilege to be a part of your meeting today, which is on the occasion of Bronchiectasis Day. Very appropriately, you've chosen the term bronchiectasis 360-degree from a neglected disease to a recognized priority, which goes in line with what the globe is thinking today about bronchiectasis. I would rather have been with you in person today. However, work and the way geographic mandates, we will do this virtually online. The topic given to me is modern evaluation of a patient with bronchiectasis. And I'll talk to you about various facets of the disease from a clinical perspective, hopefully giving you some nuggets which will help you to treat your patients better. So there are 5 stops that I'm going to use over the next 30 minutes. I'll talk about diagnostic approach. I'll talk about etiological workup. I'll, together with you, identify treatable traits. We'll talk about the geographical diversity of bronchiectasis and why bronchiectasis can never be one disease. And we'll finish off talking about the role of multidisciplinary care. So we start off with first section, which is about diagnostic approach. And we talk about cough and CT confirmation of bronchiectasis as per definition, and then moving on to a risk stratified diagnosis. So we'll start off with something which is mundane, something all of you know, but is still worth reiterating to try and put things in context. So when we talk about bronchiectasis, we talk about a chronic inflammatory airway disease, which is identified by abnormal and permanent bronchial dilatation on CT. Hence, the emphasis here is that this is a CT mandated diagnosis. The cardinal symptoms are those of cough, sputum production, and this recurrent respiratory infection. So ingrained within the definition is a CT picture. There are clinical features in the way of cough and sputum production. And most importantly, there's the microbiology where we talk about recurrent respiratory infections. It goes on to add that there's a wide spectrum of etiologies. Exacerbations are the most important facet, and they drive morbidity, mortality, and healthcare costs. And of course, my words that it is no longer an orphan lung disease because of the numbers that you see on the right of that slide. The fact that the total number of cases globally is 5.4 million. The fact that it's risen in the last 25 years by about 10 folds. And the fact that 40% of patients are still defined as having idiopathic disease, even though the actual numbers are much smaller. So what I'm trying to say is that the idiopathic number is so high because the investigations mandated to define an etiotype of bronchiectasis are still not done either partly or completely in most of the developed and developing world. So my carry home message there is that a CT report that says this is bronchiectasis, remember that's the definition. CT report that reads bronchiectasis starts off with the diagnostic process. It doesn't give you the complete diagnosis. The reason is this label covers causes, patterns, and biologies with different prognosis and different treatable traits. I take you to a slide now, a picture, a cartoon, which is straight out of the ERS 2025 guidelines. And it shows you the vicious vortex of bronchiectasis. Let me try and point out different facets of something you probably know already. So the vicious vortex has inflammation at the heart of it. This is mainly neutrophilic and sometimes eosinophilic, and there is sometimes, quite often, a local or a systemic immunodeficiency. Then there's infection, which is a chronic infection, and the bacterial virulence factors increase inflammation, reduce mucociliary clearance. The next facet is impaired mucociliary clearance and mucus hypersecretion that drives the disease. And all of this results in lung damage, more of lung destruction, more bronchiectasis, more infection, more inflammation, less mucociliary clearance, and hence more bronchiectasis. So that's why you see these cascade of arrows on there. Arrows that lead from one to the other. This is not a cycle. It's a cascade. It's a vicious vortex because the diseases, the pathophysiology of the disease are interwoven with each other. Look at the management. The management is driven by the pathophysiology. So to counteract infection, there are long-term macrolides, which are evidence-based, which reduce exacerbation significantly. Inhaled corticosteroids don't seem to work in a majority unless there is overlapping asthma and COPD along with the bronchiectasis. With infection, we have the largest amount of treatment. It's mainly antibiotic based. So long-term inhaled antibiotics, Pseudomonas eradication, and then not much of evidence for non-macrolide oral antibiotics, which are long-term. For impaired mucociliary clearance, there are mucoactive drugs. And for lung damage, there is pulmonary rehabilitation. There are new drugs on the anvil after the ERS 2025 guidelines. The guidelines do mention about DPP1 antagonists, antagonists of enzymes like neutrophil elastase or serine proteases. These cause lung destruction. So inhibitors of DPP1 or neutrophil elastase reduces lung destruction and hence halts or reduces the rate of progression of bronchiectasis. That's how I want you to think about this vicious vortex as we go along. So you've seen the commonality of the disease, the fact that it's CT driven, the fact that the symptoms are common, cough and sputum production, and the fact that exacerbations form the spine of the disease that's driven by infection. However, the etiotypes, the etiologies of disease are very different. The CT label is the same, the etiologies are different. So the etiologies in countries like ours, Sri Lanka, India, would be TB. That's the most important. Then there's ABPA, PCD, rheumatoid arthritis, common variable immunodeficiency, COPD, and quite a large number, unfortunately, remain idiopathic. However, they all converge into that one label, bronchiectasis, that we spoke about. The etiotypes are so important because the disease behaves differently due to various factors. I have just enumerated a few. So mortality is variable. In most cases, it is less than 10%. But in some etiologies, COPD, bronchiectasis, for instance, rheumatoid arthritis, for instance, PCD, NTM, the mortality can be high, sometimes reaching up to above 25%, depending on the etiology. Pseudomonas, and in our countries, Enterobacteriaceae like Klebsiella are driving factors for the disease. If you grow Pseudomonas or Klebsiella, your risks of dying are far greater as compared to someone who grows a different bug or no bug at all. Same CT pattern, however, different disease course. The nature of inflammation we have alluded to. Neutrophilic versus eosinophilic. The drug choices vary. The prognosis varies depending on whether it's neutrophil-driven disease or whether it's eosinophil-driven disease. The trials have gone wrong, and we have a lot of negative trials in bronchiectasis. That's simply because the trials try and treat bronchiectasis as a whole, not the etiotype, and hence they keep missing their endpoint. So the important message for all of us, all of you, is characterize the patient. It's not just about the CT. The CT is important to define that the patient has bronchiectasis, but your job begins once you've defined that this patient does have bronchiectasis. So confirming the diagnosis, we have said is CT, and there's bronchial dilatation. And you see a lot of bronchial dilatation on this patient of mine who has post-TB bronchiectasis. We define bronchial dilatation as an internal bronchial diameter which exceeds that of the adjacent vessel. And you can see me trying to do that on the CT picture on both sides. There's a lack of tapering of the bronchus towards the periphery. So you see this abrupt finish. There's a lack of tapering of the bronchus. The bronchus can be visible up to 1 centimeter of the pleura. You can see how distally the bronchus is extended, and the bronchial walls are sometimes thickened. Then there's mucus plugging and this tree in bud. So remember these terms, look for them on a CT. Bronchial dilatation with increased bronchoarterial ratio. There's the signet ring sign. There's lack of bronchial tapering towards the periphery. The bronchus is visible till the costal pleura, within about a centimeter of it, and the bronchial wall thickening along with mucus plugs and tree in bud. Together, all of this define the radiological definition of bronchiectasis. The location of where bronchiectasis is, the anatomical nature of the bronchiectasis, whether it's cylindrical, cystic, saccular, etc., whether it's in the right middle lobe and lingula, as it is the case of NTM, whether it's upper lobe cystic disease, as it is in the case of TB. These also give clues to the etiotype and are important to remember these. All of these patients, after the diagnosis of bronchiectasis, need a few standardized tests. And this is important in every center, every patient with bronchiectasis, and they need to be revisited when the patient comes for a follow-up. It's not enough to do it once. The etiotypes change. The etiotypes might be duplicated. There might be 2 or 3 different etiologies, and these need to be defined properly. So the mandatory workup after you've defined bronchiectasis on a CT is looking at lung function and bronchodilator reversibility. You would do a sputum culture. You would send off serum immunoglobulins in these patients. A must to send off serum IgG, IgA, and IgM. You would do an ABPA screen, which includes the total IgE, aspergillus IG, and eosinophils. You would do a full blood count, a CRP, and an autoimmune screen. So that's your mandatory tests. Next, you come to risk stratification. So I've said Pseudomonas and Klebsiella not on that slide, but both of these portend a poor prognosis. 2 or more exacerbations or 1 severe exacerbation portends poor prognosis. Remember, exacerbations are the drivers of patients with bronchiectasis. They are the drivers of the disease process. Some etiologies, like we said, they give a poor prognosis. Primary ciliary dyskinesia, COPD, RA-associated bronchiectasis have poor prognosis. Patients with NTM and ABPA have a poor prognosis. Important to do a comorbidity screen. So the ones mandated by the ERS 2025 guidelines are cardiovascular disease and osteoporosis, anxiety and depression, rhinosinusitis going by the theory of the unified airway, gastroesophageal reflux disease, and the number of pills, the pill burden, the inhalational drugs. All of these need to be revisited. You can see at the bottom in bold, I've put in diabetes. There's a study that I'll show you briefly, but we know for a fact that we are the diabetic capital of the world. When I say we, it's South Asia, which is the diabetic capital of the world. And in patients with bronchiectasis and diabetes, there's a triple whammy in the way of inflammation. You are post-TB, you have diabetes, you have inhaled corticosteroid use. I'll show you in a moment that this is indiscriminate in our part of the world. And these 3 together drive infections. Infection drives inflammation, and there's more lung damage. So remember to check for diabetes. I'll say this a few times through the course of this talk, but do check for diabetes in your patients with bronchiectasis. This is the Lancet paper we are very proud of, got published about a month ago, and it looked at comorbid diabetes and the severity and microbial changes in patients with bronchiectasis. Massive study, more than 30,000 patients, 33 different countries, and this included embark from Europe, the Indian data, the Chinese data, the Australian data. So very large and robust study. Very briefly, what did we find? The findings were soul stirring. They would make you sit up. So, older patients, more of men, remember bronchiectasis normally has a predominance of women, but with a coexistence of diabetes and bronchiectasis, they are older, they are more male, they have higher BMI, they have more COPD, more of cardiovascular disease, and higher bronchiectasis severity indices. They do poorly. That's the answer to how do they do. There's 18% more exacerbations. There are 57% more hospitalizations. There's 80% higher 5-year mortality. So that's how bad the numbers are when these two diseases coexist. And the microbiome shifts. There's much more of Enterobacteriaceae, more of Klebsiella and E. coli here. There's more of Moraxella and Haemophilus influenzae. And the galectin 4 and GDF15, which are markers of cardiovascular comorbidity, markers of MI and heart failure, these go up significantly when bronchiectasis and diabetes coexist. So carry home message. There's lots of patients with coexistent bronchiectasis and diabetes who would die of cardiovascular causes rather than respiratory causes in patients where these two diseases coexist. So important message for all of us, but especially for us in this part of the world, diabetes should now sit alongside pseudomonas and frequent exacerbations, and they will be a red flag in risk stratification for bronchiectasis. We do not know whether metformin works in reducing risks from bronchiectasis and cardiovascular disease. The numbers were not large enough in this very large study. We didn't do the drug follow-up the way we would have or wanted to. However, that's for future studies. The management is for future studies. The risks for stratification is today. Hence, the carry-home message again, do check an HbA1c when you screen your patients with diabetes for the first time. Risk stratification in every patient with bronchiectasis in our part of the world, there's a few scores, but for us, the most important one is the bronchiectasis severity index. I won't read through this for the sake of time. However, these 9 parameters of the slide in front of you together add up a score where the score of 0 to 4 is thought to be mild disease, where the mortality is less than 3%, whereas a score of more than equal to 9 is severe disease and indicates a mortality of more than 10% often. And this we are talking about 1-year mortality, remember. So mild disease less than 3%, severe disease about 10% or even more than that. Important to remember these factors, important to record them in your prescription when you see your patient for the very first time. The next thing is identifying a higher risk patient. And we've said all of this, but just for the record, just for all of you to remember, because this should be a part of your prescription for every patient at every visit with bronchiectasis, chronic pseudomonas infection, or any other gram-negative, and I've mentioned Klebsiella repeatedly now, COPD, PCD, and RA-associated bronchiectasis of higher risk, 2 or more exacerbations or 1 hospitalization. This is different to the previous guidelines, and I'll come back to again. However, these add significantly to the risk stratification. Purulence of the sputum and persistent purulence is important. NTM infections and ABPA or severe aspergillus sensitization is of great value. So remember these high risk factors and record them. The next section for us is etiological workup, finding the cause. This is not an option. It is compulsory to do so in every patient with bronchiectasis. And I say this especially because when we did the bronchiectasis India registry back in 2017 to 2019 for the initial recruitment, the numbers for us were miserable. And I use that word understandingly, miserable. 3% of the 2195 embark patients had full guideline etiological workup. So full guideline etiological workup, the way I described a little while ago, but that's the teeny weeny small percentage of people who had that workup. If you did the immunoglobulins, so the IgM, the IgA and the IgG, the total IgM A and G, and the aspergillus screen, your numbers with etiology would go up from 10.5% to 26%. If you manage to screen an unselected population of patients for primary ciliary dyskinesia, you would have 12% of your so-called idiopathic having PCD. Consider that number. That's a large number. So screening, trying to find etiologies, does find etiologies which are often unexpected and large in number. So my carry home message from that slide, doing this bundle is mandatory. It's not just for atypical cases. There are etiotypes like ABPA, CVID, COPD, NTM, primary ciliary dyskinesia. If you treat the underlying disease, the bronchiectasis in these patients improve, the infections become lower, the exacerbations get lower. So these are treatable traits. It's important to identify these etiotypes and treat them along with the management of bronchiectasis that you do. And I've said this a few times, but just quickly for you to see this slide again. 6 tests ordered once, reclassify, and a large share of idiopathic goes away. So fluid blood count at differential looking for eosinophilia, the aspergillus screen, the immunoglobulin screen, the sputum test, looking for your short autoantibody screen with rheumatoid factor, anti-CCP and ANA. And in select cases, nasal nitric oxide and sweat test is what we spoke about. In Mark India, the etiological mix is there in front of you. You can see the etiologies, the large ones, as you see, are post-TB. The green there, 22% is post-infective. Then you have idiopathic, and then you have EVPA. Important message that in the Indian registry, the question which came with the highest yield, the highest number of yeses, is have you ever been treated for TB? More than 40% of patients had a prior history of TB in the Indian registry. Hence, ask every patient in Sri Lanka, ask every patient in India whether they've had TB in the past. Having TB in the past in TB endemic countries like ours, and then having post-TB bronchiectasis are not always the same. Important to remember that. Important to look for other etiologies also in these cohorts, but that's a judgment that you need to take. What cannot be replaced, what cannot be changed is that the question, have you ever had TB, should be asked everywhere. The other important fact on this slide is that ABPA is about 9%. Interesting that we tested for ABPA in our registry only in 18%, 50%, 50% of them came back as positive. Hence, we under-tested, we still got to 9%, and hence, testing for ABPA is compulsory in our part of the world. You will pick up cases of ABPA bronchiectasis. So post-TB bronchiectasis is an etiology most guidelines miss. The guidelines come from Western countries. It is only this time that Asia has participated. I have participated in the making the ERS guidelines, and hence there's lots of mention of diseases from our part of the world. 40 to 80% of people who survive TB have microbiological cure, unfortunately keep on having symptoms thereafter. So there is the end of an acute disease in the form of TB. However, the chronic disease, post-TB lung disease, becomes the sequelae in these individuals. The post-TB numbers are the greatest in South Asia. It's the greatest in India. And when people have starting symptoms, important to find out whether it's a sequelae of TB or whether it's the reactivation of TB. And the only way to do that would be to do microbiology in these patients along with imaging. Imaging does not give you microbiology. You need to do the sputum or the bowel in these patients to find out. And this is as relevant in Sri Lanka as it is in India, and remains underrepresented in the Western world. A little bit about post-TB bronchiectasis. I'd be amiss if I don't mention this. I show you a short case, which is just an example that all of you would see. 45-year-old man, antitubercular drugs completed 10 years ago, recurrent hemoptysis, recurrent exacerbations, upper lobe cystic disease with fibrosis. The red flags, the identifying factors there, patients have a documented past history of ATD intake, upper lobe cystic disease along with fibrosis, hemoptysis. Important to remember, a lot of these patients will have chronic pulmonary aspergillosis. The symptoms might not be due to recurrence. It might not be due to just the bronchiectasis. It could be that these patients are chronically infected by Aspergillus, CPA, and that needs to be diagnosed. TB is a leading cause, as we said, of bronchiectasis in India and, of course, Sri Lanka and all of South Asia. Important to remember to screen for TB or for CPA in these individuals. And one last point, now it's the era of DPP1 antagonists. We wonder whether giving patients completing ATD treatment, drugs which are DPP1 antagonists, whether they can prevent onset of bronchiectasis. This is now a theoretical question, but there'll be studies from ourselves which will try and prove or disprove this. So that's my etiotype sheet. So it shows the etiotype. It gives you a clue to the diagnosis. It tells you about the tests that we have discussed already and how there's a treatment change. I won't read through all of this, but let's take one or two examples. So at the top, ABPA, this will be refractory asthma not responding to standard treatment. The patient will complain of coughing up brown phlegm, brown sputum plugs. You would test for total IG, Aspergillus IG, IgG, eosinophils, and you would treat these patients with steroids and azoles, and the underlying disease gets better. Take another example, chronic variable immunodeficiency. This is childhood onset disease. These patients have cyanopulmonary infections. You do a quantitative IgE, you do subclasses of IgG, you do a vaccine response in these patients, and if they have CVID, you would give them immunoglobulin replacement. So you know the management of these diseases. Treating the background etiology, remember, improves the bronchiectasis in these patients. I've come to the last 5 minutes of our talk, and we'll talk a little bit about phenotyping and endotyping and treatable traits. So remember, when you look at bronchiectasis, you should do it with three lenses. The first lens is, why do I have bronchiectasis? What's the etiology? So that's the etiotype, and you know there are multiple causes for it. The second question is, what does my bronchiectasis look like? What is the pattern of disease? What's the phenotype? And this could be frequent exacerbator, it could be chronic pseudomonas, it could be bronchiectasis in the elderly, multiple phenotypes. The third question you ask is, what drug fits best in my patient with bronchiectasis? What is the biology of the disease? That's the endotype. This could be neutrophilic, this could be eosinophilic. So bronchiectasis is not a disease bundle. It is an individualized prescription, which you look at through the three lenses of etiotype, phenotype, endotype, and the endotype should tell you how exactly you treat that disease. I've gone through this before, the classic patterns with distribution, defining factors in the typical patient. I won't repeat this, but important to stress, phenotype of patient is important. This is the study I spoke about a little while ago, which defined in a novel manner the frequent exacerbator. We went away from 3 or more exacerbations in a year. So that was the previous definition, 3 or more exacerbations in a year, the frequent exacerbator phenotype, to this graded risk, 1 exacerbation, the incidence rate ratio 1.42. You can see how the risk keeps going up. With 4 or more exacerbation, the incidence rate ratio is about 3. Severe exacerbations, however, matter much more. 1 prior severe exacerbation, and that's defined as someone who has an exacerbation severe enough to have IV antibiotics or get hospitalized. The incidence rate ratio is more than 4 exacerbations at about 4. So severe exacerbations beget severe exacerbations, and that's very important to remember. The neutrophilic endotype we said is the most common. These patients have a lot of neutrophil elastase and other enzymes which destroy the lung. Increased sputum neutrophil elastase reduces FEV1, increases exacerbations, increases mortality. The sputum looks purulent and green. That's neutrophilic disease. This is a study we published in Thorax about a year ago, and it shows you the color of the sputum, mucoid, and this should read as very purulent. So mucoid to very purulent. And depending on sputum purulence, the more purulent your sputum, the more severe the disease, the greater the exacerbation, and more the mortality. So just macroscopic examination bedside doesn't become easier. Open the sputum pot, look at it. You know it's neutrophilic disease. You know, based on the purulence, what your disease severity is like, what the exacerbations are likely to be, and how mortality would be. The other phenotype, which is about 20% of your patients with bronchiectasis, is the eosinophilic phenotype. And these patients do a bit better. Patients with very low eosinophils and very high eosinophils do worse. So it's a U-shaped curve. It's like mortality in someone with pneumonia in the young and the very old. Similarly, high eosinophils and low eosinophil both portend a poor prognosis. However, it's a better disease than a neutrophilic disease. It's more a streptococcus dominant microbiome, less pseudomonas, and these are the patients who respond to inhaled corticosteroids. And you should select these patients wisely. There also are ongoing trials using biologics in patients with eosinophilic bronchiectasis, but it's still watch this space. So that's treatable traits. The etiology could be COPD, asthma, NTM, ABPA. You treat accordingly. You look at infection. Is it Pseudomonas? How would you treat the Pseudomonas of Klebsiella? You look at the inflammatory phenotype or the endotype rather, whether it's neutrophilic or eosinophilic, and you look at symptoms. Does the patient have breathlessness? You would do rehab and give bronchodilators. Does the patient have hemoptysis? You would do conservative medical management versus embolization versus surgery. Remember, inhaled corticosteroids is only good in three categories: the eosinophilic bronchiectasis, the overlap with asthma, and the overlap with COPD and ABPA. Inhaled steroids is not for everyone. More than 60% of patients in the Indian registry were on inhaled corticosteroids, and that's treating your patients wrong. And we spoke about comorbid diabetes, the fact that it's a killer. There is 80% increased mortality over 5 years, and this needs to be picked up at diagnosis. So those are the key recommendations from the ERS guidelines. Again, I'll not read through these because I've run out of time, but do look at them and it gives you the evidence-based treatment. The fact that long-term antibiotics should be used in people with 2 or more exacerbations or 1 severe exacerbation, and your choices are airway clearance, long-term macrolides, inhaled antibiotics, and non-macrolide oral antibiotics for which there's very little data. There's huge diversity in bronchiectasis, diversity in etiology, which we have spoken about repeatedly. The frequent exacerbator phenotype, more the number of exacerbations, greater the chance of the next exacerbation. The more severe the exacerbation, the greater the chance of a severe exacerbation. We've talked about the heterogeneity of neutrophilic versus eosinophilic disease, and we've talked about the endotypes and what you order. So blood eosinophils, looking at the sputum, looking for chronic infections like Klebsiella and Pseudomonas, doing the CRP in the stable state to look for the inflammatory load, and to look at exhaled nitric oxide to identify T2 phenotype. And the fact that there's a lot of geographical variation. If you look at the study which we published in Respirology a little while ago, Asia versus Europe versus Australia, the age is different. We have a younger population. We have more men. We have more of comorbidities. Our BSI scores are higher. We have less of exacerbations, but more of hospitalization for some strange reason. And we have more of Klebsiella. So distinction between various geographical areas is also of great importance. And the fact that COPD bronchiectasis overlap is very important in our country. The numbers are significant, and these patients die the most. They have more of pulmonary hypertension, and that's another phenoendotype that's worth remembering. Finish off by talking about the multidisciplinary team. Its various etiologies span specialties. So ABPA, primary ciliary dyskinesia, combined variable immunodeficiency, rheumatoid. You would need specialists from various areas. You have comorbidities, and hence you need specialists from various areas. Airway clearance is a skill. It's not a prescription. You need good, talented physiotherapists to do that for you. And the unified airway is real. You need your ENT colleagues to help you in the management of this disease. And that's the MDT we speak about and don't have. The fact that you form, as a pulmonologist, form the core of that MDT team. However, there's the physiotherapist, the microbiologist, the ENT, immunologist, radiologist, dietitian, thoracic surgeon at times. All of them should hold hands in the management of this disease, which has a lot of morbidity. We have just started Embark, the Indian Bronchiectasis Research Audit Collaboration, the second and detailed part. There are facets of it which no one has looked at across the globe. And we need to do this. We need to do things as a multidisciplinary team rather than individuals fighting this dreaded disease. We have spoken about the integration with ENT. We have spoken about airway clearance and pulmonary rehab. In every patient with bronchiectasis, this is something that's non-negotiable. And then there's Embark that I mentioned, and I don't have time to go through, but important to remember this. My take-home message is the fact that you need to diagnose properly. HRCT, remember, is the beginning. You need to do the workup that I mentioned. Try and find an etiotype in every patient. A diagnosis of idiopathic bronchiectasis is like a black mark against your medical expertise. So try your best. You will still not manage in a few, but do try your best. Treat traits, do not treat labels. Respect the diversity we spoke about and build your multidisciplinary team. And I'll finish off now. I've shot over time by 5 minutes, so apologies. But to invite all of my friends in Sri Lanka, the Sri Lanka College of Physicians, the Airways Disease Vertical, all of you to come to NAPCON in Kolkata. We'll try and do this well. We'll try and do this like a global conference with all of you together. Do come. It's the 29th to the 31st of October and the 1st of November. Let's create magic together. You've always stood by our side for conferences, and we have done yours with you. So do come in large numbers and be a part. Write a line to me if you are interested in participating. Thank you very much for listening, and I hope you have some questions which I'll answer. And I hope you have a great day discussing bronchiectasis and the overlaps.
Okay, thank you very much, Dr. Da. Shall we show our appreciation in the usual way, please? Thank you very much, Dr. Da, again, for your contribution to this session, as well as your contribution to improve and develop our registry in bronchiectasis. And you are really an ambassador to this region to improve our level of care in this particular subject. There are a few questions from the online group. Somebody has asked, if CT facilities are limited, can we use any alternative way of confirming bronchiectasis?
This is Amit. We have met on a couple of times, and the last time we had a discussion in the. It's a pleasure to hear from you and see you. So my question is about, you mentioned that 12% of your patients had ciliary dyskinesia. Was any of these patients in these groups, the other idiopathic group, analyzed for specific polysaccharide antibody deficiency and vaccine responses? What is your feel that maybe the isolated profile, like identifying Haemophilus and pneumococcus in the sputum, might provide a clue? Do you have any data on specific polysaccharide antibody deficiency and your cohort of patients were vaccine responses checked?
That's a great question. The first point to clarify is that this is not our cohort of Embark. This was the UK cohort, where one of my colleagues and friends, Amelia Schumar, who has done great work in the area of primary ciliary dyskinesia, looked at a cohort of about 600 patients from the UK, a lot of patients from Dundee, and did genetic screening in these patients and found a cause which was genetic, mainly primary ciliary dyskinesia, in 12% of patients who were previously labeled as being idiopathic. Now, that's all I know. The paper said this. I don't think they looked at vaccine responses, etc. In India, probably similar to Sri Lanka, we can only do vaccine responses in a select few centers, including ours. So we looked at a cohort of about 250 patients as a part of our original Embark, and we found that vaccine responses and immunodeficiency was present in about 16% of these patients. So 16 is a large number. These were also previously labeled as being idiopathic or post-TB, and some being post-infective. And we found that vaccine responses actually picked up immunodeficiency in some, when the immunodeficiency was not so well documented just by measuring the blood levels of IgG, IgM, IgM, or the IgG subclasses. But that's the only data I have from India. The 12% I quoted was actually data from the UK.
Thank you very much for that response. In Sri Lanka, Dr. Rajiv De Silva, Rajiv De Silva, who is a senior immunologist, had done some work which is much quoted and cited using the typhoid vaccine as a surrogate for the pneumococcal vaccine, because the pneumococcal vaccine is very expensive. This is data done some time back, and I think this is not specifically addressing bronchiectasis, but he had a cohort of patients whom he had used the typhoid vaccine. It's,
Wonderful. And what was the result?
I cannot quote it off my hand,
Right.
but this was but it is available on the. I'll get the reference for you.
No, absolutely. So I'll have a read. Wonderful.
Dr. Da, another question from Bangladesh. Is there any way to train physiotherapists regarding bronchiectasis by a joint collaboration, say India, Sri Lanka, and Bangladesh? Actually, this question came from somebody in Bangladesh, a participant.
So that's a great thought. I think meetings like this, meetings like the one that you're hosting just now, are great platforms to set up training networking sessions. So I'm all for trying to set up. We have something we have set up in India, which is supported by a pharma company, where we do some online sessions followed by hands-on sessions in various cities. And we empower the local physicians in imparting training to physiotherapists, technicians, etc., by doing it as per a set module. So if some of us like-minded doctors with an interest in bronchiectasis want to come together, we can try and do a South Asian one where we train. I mean, it's very much required. The backbone, the spine of management of bronchiectasis, according to me and a lot of other friends and colleagues of mine, is airway clearance. Unless we have support from our physiotherapists and nurses, I think it's well nigh impossible to treat bronchiectasis as well. That's a great thought from our colleague in Bangladesh, and I'm all for it.
Yeah, one last question, because some other questions are there, but we will be covering them in the subsequent topics. And the question is, you mentioned that the BSI is the best tool to assess severity in our part of the world. Can you please explain why BSI is the best?
So that's a very interesting question, and I'll give you a slightly 1.5 minute detailed answer. So what we did as a part of our original MBAR was to look at the FACET scoring, which all of you would have heard about, and the BSI scoring. And the validity of a BSI in predicting exacerbations was about 20% better as compared to what FACET showed. Now that still does not answer the question as to why it is better. We also found that the follow-up patients of MR actually had certain markers which were not covered by the BSI. So we have come up with a score which we think is more relevant for South Asian patients, which is called the Modified BSI Index, which we will try and validate as a part of the new Indian bronchiectasis collaboration study that we are starting in the next couple of weeks. So this has some differences. For instance, for us South Asian patients, the mean age for onset is 10 years younger for our bronchiectasis patients as compared to what it is for the rest of the world. Klebsiella is a great offender in our country. It's not so for the Western countries. So the score is a modification. So the BSI will become better going forward. We will have a better score, but it's watch this space for the time being.
Okay, thank you very much, Dr. Da. Really appreciate your time and dedication.
Thank you very much for having me, and have a wonderful conference. And I hope to see all of you soon. Do come to NAPCOL if you can, and I'll keep in touch. Thank you.
Thank you very much.
Thank you.